Good afternoon, ladies and gentlemen. I'm Zhang from Peking University Cancer Hospital. So it's my great honor here, and thank Dr. O and the academic committee to invite me here to share the opinions of the hereditary gastric cancer in China. Yes, of course. So it's really a very difficult disease, and so maybe we will talk from these 6 aspects. The first, of course, how frequent of the disease. We know that about 90% of the gastric cancer are sporadic, but yes, it still have 10% of the gastric cancer are familial aggregated, and 1/3 of them will be with a genetic background. So we call them, and even some of them will be hereditary tumor syndrome with other malignancies at the same time. So in fact, we do have a very unique story of hereditary diffuse gastric cancer. It is a bit different with just the hereditary gastric cancer. So in fact, initially, hereditary gastric cancer was found in 3 Maori lineage of New Zealand, and later, more and more familiar aggregated gastric cancer were found in Caucasians. Yes, you know that is not frequent thing in our Asian countries. And in fact, the pathological findings are very characteristics is of the diffuse anal signet ring cell carcinomas. So we call it HDGC. So in fact, the diagnosis of the HDGC families has been modified from the initial 1999 criteria to later 2015 criteria. So in 1999, first RGCC, the International Gastric Cancer Association, so made this clinical diagnosis criteria of the HDGC families. The family, they will be diagnosed as HDGC if they meet one of these conditions. So first, should be 2 or more documented cases of diffuse gastric cancer in first or second degree relatives, with at least 1 diagnosed before the age of 50. And the second condition is that 3 or more cases of documented diffuse gastric cancer in first, second degree relatives. It depends on the age of onset. But later, 6 years later, the diagnosis was modified because we found that many people, in fact, they have other second malignancies. So the criteria has been modified to these 3 conditions. If they meet only one of them, each of them is okay. First is among the families, 2 or more than cases documented gastric cancer, or 1 who were diagnosed as diffuse gastric cancer. And so the second, if the patient with no family history, but the families with diagnosis of diffuse gastric cancer with the age of onset less than 40 years old. And the third is a family with a diagnosis of both diffuse gastric cancer and lobular breast cancer, include one with the age of onset less than 50. So it means that the criteria of the clinical diagnosis of the HDGC families changed a little. However, the clinical diagnosis is not equal to the molecular findings for HDGC. In fact, it differs from the early stage to the later stage. In fact, we think that the hereditary gastric cancer would be very malignant with very poor biobehavior. But in fact, in the initial stage, they are very indolent at that time. They may be multiple foci and with signet ring cells, and they will limited in the superficial lamina propria, and they do not have nodal metastasis. And at that time, we call them indolent. They will grow and spread, just in the lamina propria. Okay, excuse me, yes, just in the propria. And this figure is a T1A signet signet real cell carcinoma here, and it's with the cells have rare mitosis. But however, if it moved into the late stages, we will see the finding of the lineages plastic by the endoscopy or by CT scan, and with the pathological findings of diffuse type, and we can see large amount of signet ring cells at this time. Especially, they will be found at the corpus and antral transition zone at these areas. And some cases will show a significant increase in density and size of these cells. So So what's behind of the familial gastric cancer? Or is there any driver gene when familiar with CDH1 mutations? And first, this gene was found. Its mutation can be found in about 40% of the HDGC patients. And in fact, all these patients will have higher incidence of lobular BC and colon cancers. So CDH1 mutations, in fact, they have about 120 kinds of mutation. Not all of them have function, not all of them are activity mutations. CDH1 mutation are also documented in a few early onset diffuse gastric cancer patients without a family history. And also, they will show some deformities of hair lip or the cleft palate. And so it is also recommended for those patients who with these deformities, some experts will also recommend them to have the CDH1 mutation test. And for those who have CDH1 mutation test, and if they are carriers in a family, the lifetime risk of developing a gastric cancer is about 80%. Is really very high. In fact, CDH1 mutation really play a very key role in the etiology and the mechanism of HDGC. And as a tumor suppressor gene, it produced the E-cadherin to maintain differentiation, polarity, and architecture of epithelial cells. So we can understand that why it is more. It can be found more in the diffuse type, so the cells lose their adhesions. So if it is HDGC families, so what should we do for these families? First, we will elaborately do gene tests in the 3 generations, not only the patients themselves, and we will find histopathological confirmation of whether the patient has diffuse GC or also do they have the lobular BC. And the CDH1 screening should cover all family members. And if CDH1 mutation in family members was found, we will confirm the mutation, whether it's only polymorphic or it's a pathological mutation. And so finally, if we find a family who meet the clinical diagnosis criteria of the 2015 criteria issued by the IGCC, and we test the patient and his relatives of the 3 generations of CDH1 mutation. And so next, what should we do that? Of course, we should reset if resectable. And the very important thing that, so we just mentioned the lifetime risk of developing gastric cancer in these patients, CDH1 carrier, mutation carrier is about 80%. So it comes the question whether we will resect the stomach before it has any phenomena or any confidence that it already has gastric cancer. So this is one thing, one problem. Another problem is if the patient too late when they diagnosed them, they have metastatic settings. And it's very, very repeated that they will have very poor prognosis. And for women, they will also have ovarian metastasis. So since we just noted, said that there should be multiple foci, so we recommend the total radical gastrectomy. Even the lesion might be very small, just as an interim, we will recommend the total radical gastrectomy. And so later, the pathologist will give very cautious diagnosis of the primary signature ring cell carcinoma or diffuse gastric cancer, if even the lesions are small or at a very early stage. So should we do the prophylactic gastrectomy is really a question. Although it is recommended by the consensus guidelines of its mutation carriers, but in clinical practice, it is hard to make this decision. The doctors should have the discussion with the patients and their relatives and the family members. And so 5 years ago, Steve Van Ham did do some research about the prophylactic gastrectomy, and in that 60 families, they found 220 CDH1 mutation carriers, and among them, 160 accepted prophylactic gastrectomy. And it's very important So the preoperative endoscopy, about 62% of the patients are negative findings. However, after the post-operative specimens, we can see that about 70% of the focal signaling ring cell carcinoma can be found. So it seems a very normal stomach. However, it really already has a signaling ring cell carcinoma. So the next question, the first question, should we do? The next question is how to do. So you know that for gastric cancer, we will have the lymph node dissection, but for the mutation, CDH1 mutation carrier, if we do the prophylactic gastrectomy, whether should we also do the lymph node dissection is a question. Since the most foci will limited in mucosa, so less risk of lymphatic metastasis. So whether to do or not, depending on surgeons, depending on the findings intraoperationally or something else. But the pathologist should be very, very cautious, since many signaling ring cells may be very hard to find, and even the mucosa seems very normal at the early stage. So in 1937, we have a technique called Swiss roll technique, and by this technique, the specimen will be treated to make it a roll, and later to embed it in the person, and at that time for the doctors, for the pathologist to observe and make a diagnosis. It is said that they can find the foci less than 3 millimeters signaling ring cell in the lamina propria. So we can say, yes, it's a figure of this technique. And this is a figure that we can see this is a case who has CDH1 mutation, and who had the prophylactic gastrectomy. And we found that here is infiltrating tumors, but another 36 foci, they have T1A signaling ring cell carcinomas. It's detected by this Swiss roll technique. So it is recommended to test for the pathologist to make a diagnosis of the diffuse gastric cancer with a family history of CDH1 mutation. But it has a dilemma to have the follow-up of those who made clinical diagnosis of the criteria of the HDGC, but who do not have CDH1 mutation. What should we do for that? We are not sure. In fact, only about less than 10% of the Asian people will have the CDH1 mutation. So currently, we have no consensus on that yet. But for the healthy, maybe we have the seems healthy CDH1 germline mutation carriers. For the follow-up stomach, I think that annual endoscopy should be offered. But for the gastric still, the stomach still there. But for the prophylactic gastrectomy is already performed, and the several suggestions to the pathologists, they should be pay attention to. That it means that for the whole gastrectomy specimen, at least 5 biopsy specimens at the pylorus, the corpus intrum, and these 5 places should be, should be made the specimens. And multiple biopsies in corpus intrum transition zone is also recommended. But however, the endoscopy staining is not recommended routinely, since the mucosa should look at the normal one. And also, we should keep very close follow-up of the breast and colon. If the patients, after they are 35 years older, they will have the physical examination twice a year, and have the ultrasound or the MRI once a year. And for colorectal cancer screen, if they are 40-year-old, and we notice that the youngest onset of the age is about 10 years old, really very, very young kid. So the schedule for colposcopy is about every 3 to 5 years. Whether it's enough or not, we are not sure, since the few numbers of these families. So finally, I would spend a few minutes on the current status of diffuse gastric cancer in China. Yes, we just talk about diffuse gastric cancer now. For the diffuse gastric cancer, it is classified by Lauren classification. It's a diffuse type. In fact, it's not rare among young people. and it already is usually with late stage and will show very rapid recurrence and metastasis even after the radical gastrectomy. And the patient will have the peritoneal dissemination, the malignant ascites, and for the males, females, they will have the ovary metastasis. And for the hereditary diffuse gastric cancer in China, in fact, we are not. It's a pity that we do not have the registration systems, so the studies are very limited, and most of them are case reports only. So less evaluation of HDGC and CDH1 germline mutation because of the doctors, their lack of awareness, and we do not establish a lab on a qualified lab or SOP for CDH1 mutation test. Of course, we can do it now, but it cannot be in a central lab and in every cities of China. So, yes, so it is very difficult in China to have these HDGC studies. First, we are getting smaller families since China has a long time have the one-child policy. And the second is about the civilization of the country. Many people moved from the rural area to the big cities, so it is more difficult for us to collect the samples of their relatives. And of course, the regional difference CDH1 mutation in the fruncation, in the type, whether it's pathologic or it's not, it has a regional difference. And also the thing that we should pay attention to, the HDGC does have higher frequency incidence in the Western than in Asian people, Japan, Korea, and China. We do not know the reason, because of race, environment, or the data, or anything else. We are not sure. But anyway, we are just doing a study to evaluate this. So our center, Professor Lin Shen, invited as a leading PI. We had 21 centers, and including Beijing, Nanjing, big cities, but also with some Henan province, west of China, and North China, some rural areas, to do these screening studies. For these studies, we will recruit patients and their families who meet the clinical diagnosis criteria, and we will get the germline mutations test and confirm the genes that we found. And finally, we would like to establish screening criteria for HGC in China. And so we are just following the schedule, and until the end of this year, we are planning to have recruitment of the 40 to 50 family pedigree, and we will have the panel analysis. And for stage 2 until 2020, and we will have expand the sample size. And about 2021, we would like to have the panel modification if we can do find some new genes or establishment of the long-term follow-up systems. So it's the panel of our candidate genes, including APC, BRCA1, BRCA2, and other ATM and other genes. And in fact, we have 2 criteria. One is for adenocarcinoma with GC, esophageal adenocarcinoma, and duodenal carcinoma, and with patients with less than 30 years, 35 years, 50 years, we will have different inclusion criteria. But also, you know that esophageal squamous cell carcinoma is really very with high incidence in China. So we will also include this kind of patients, and we also have the next 3 inclusion criteria. And currently, we have 44 patients, and the proud band of the pedigree of 44 numbers. And among the 44 cases, we found 5 suspected pathogenic mutations and 1 determined pathogenic mutations. And so this is the family pedigree. And very interesting for this determined mutation is a multiple primary carcinoma, and it has a MLH1 germline mutations. So finally, I want to show some take-home message. So HDGC is an autosomal dominant disease associated with CDH1 mutation, and will have high risk of developing diffuse GC and or breast cancer. So the family members should have CDH1 mutation test, and the CDH1 carriers should be closely followed up, and the prophylactic gastrectomy should be discussed. No CDH1 mutation members should be closely followed up, including the breast and colon follow-up. And a very important thing is in China, so what's the future? So of course, I think more education is needed to doctors, not only the medical oncologists, but the gastroenterologists, but the pathologists. Even we need a genetic consultant board. And I think we need a family pedigree follow-up system, a registration system, and finally, I think we will try to establish consensus on screening criteria, on the process of genetic tests and the management. So thank you, and welcome to our hospital if one day possible. And I'm sorry that I should leave earlier, but I hope I can leave my email here and to the committee. So any questions or comments are welcome. Thank you very much.